All right, welcome back. We're going to finish up the heart with this lecture. So let's get going. Hide myself here. All right, so we're going to talk about cardiac output. And when we're talking about cardiac output, what we're talking about is basically you can see this, the amount of blood being ejected from the left or right ventricles into the aorta or pulmonary trunk each minute. So basically, this is a function of our stroke volume as well as our heart rate. Okay, so just a couple of numbers for you. So again, this is sort of textbook numbers, use males, and again, very, I don't know, average size males, average health condition as well. You can assume somewhere around 70 milliliters per beat for stroke volume and roughly somewhere 75 beats a minute. So you multiply those two numbers, you convert the milliliters into liters, and you get something like 5.25 liters per minute that the heart is actually pumping. Okay, so basically your entire blood volume is going to flow through that pulmonary and systemic circuits every minute, which is really impressive. Okay, and then we have this concept of cardiac reserve. So this is our resting rate, but I think obviously when you start working out, your heart rate's going to increase, for example. So will your stroke volume because a little bit more blood's coming back to the heart. So as these two, and at some point you hit a maximum, like your heart can't beat any faster, and there's only so much blood that it can hold, and that would be like your cardiac maximum, your cardiac output maximum. So simply you would calculate that the exact same way. You'd get, and someone would have to tell you. You wouldn't necessarily know your stroke volume by yourself, but I mean you can calculate your heart rate. You just kind of put your finger up to your pulse, and you can feel your heart rate, your pulse, and you just count that for your heart rate. But in any case, you'd be given these numbers. You'd be given the stroke volume and the heart rate at maximum, and then simply you'd multiply them. And then you subtract the resting value from the maximum value, and that would be your cardiac reserve. So basically what that means is it's the reserve volume. It's the extra that your heart could pump if it had to. Right? You can see here, and typically that cardiac reserve is somewhere about 4 to 5 times the resting value. Oops. All right, so let's just talk about some of those things that actually regulate stroke volume. Okay. We have 3 things. We have something called preload, contractility, and then afterload. And just in general, preload, we can think of this as the effect of stretching on the heart, and then afterload is the force to be overcome. But we'll talk about them separately. Oops. All right. So basically, preload is the degree of stretch on the heart before it contracts. All right. So greater the preload, that increases the force of contraction. So basically, this was ended up kind of formulated by these 2 individuals, Franks and Starling, into the law of the heart. So basically it says the more the heart fills with blood during diastole, during rest, the greater the force of contraction during systole. Okay, I don't think that's necessarily that surprising. So the more it fills with blood, the harder it's going to contract to push all the blood out. Okay. And then that preload is proportional to the end diastolic volume. Okay, so basically it's going to pump out as much as it gets, I guess. So things that will determine that end diastolic volume, okay, again, the duration of ventricular relaxation, ventricular diastole. So the longer the ventricles are relaxing, the more they can fill with blood. The shorter the period, the less blood they will fill with. Okay. And then the other thing that's going to affect that is the amount of blood actually coming back from the systemic circuit to that, to the right atrium, to the right ventricle. Okay. So those are the things that are going to affect preload. So again, the longer your heart waits to contract, the longer the ventricle can fill with blood, the greater the force of the contraction. So that's preload. So contractility is simply the strength of the contraction. Okay, and we have different things that will affect the strength of these contractions. We have something called positive inotropic agents, and positive inotropic agents are going to increase contractility. And usually this is via increasing calcium inflow. Remember, by having an increasing calcium inflow, we can prolong that plateau. The longer the plateau, the longer the contraction. Okay. So basically that's going to increase our stroke volume because the more you can contract, the more you can squeeze out. And so some of the things that will also affect this are epinephrine, norepinephrine, as well as Digitalis. Epinephrine and norepinephrine will also increase the strength of the contractions as well as your heart rate, so they kind of do both. So it goes faster and it pumps stronger. And I don't know how many of you guys know about Digitalis. So Digitalis actually comes from a plant called foxglove, and it's one of the very earliest known sort of medicines from nature that we have. It's been described in medical textbooks, particularly like English textbooks. I'm not like English textbooks. And basically, again, it's a positive inotropic agent, so it'll increase the contractility of the heart. It's even often prescribed, well, Digitalis is, not foxglove, but Digitalis is often prescribed today for problems with atrial fibrillation as well as some ventricular problems as well. So it's still used today, obviously in a more purified form. Back in the olden days, like colonial days, they would have made a tea out of it. Dangerous, however, because there is toxicity. Like you have too much, and then obviously you can have some serious heart problems. Okay. We have positive inotropic agents that will increase contractility. We also have negative ones that decrease contractility. So some of the things are anoxia, so lack of oxygen, acidosis. Again, those two kind of go together. Not surprising, some anesthetics. And if you have an increase in potassium in the interstitial fluid, that'll also decrease contractility because basically it's interfering with the heart's ability to contract. All right, and then last but not least is this idea of afterload. So simply, it's the pressure that has to be overcome before that semilunar valve can open. Remember, as the ventricles contract, they're pushing blood out the pulmonary trunk and then the aorta. So they have to get it past that pulmonary semilunar valve as well as the aortic semilunar valve. And there's blood there, right? I mean, there's blood all throughout you. So there's blood on the other side of the semilunar valve. So if there's a lot of force, like resistance on those valves to open, that causes an increase in afterload, right? And basically what ends up happening is if there's an increase in afterload, it's hard to push that blood out, and a ventricular contraction is only so long. So at the end of that ventricular contraction, some blood will end up remaining in the ventricles. So basically it's not as efficient, right? You're not getting as much blood out as you should. So things that will increase this afterload, some things that will increase pressure in your blood vessels are things like hypertension, so high blood pressure, and basically plaque buildup in your blood vessels, right? That also leads to hypertension. Okay. Again, cardiac output depends on heart rate and stroke volume. It's really important that we have these adjustments in heart rate on the short term. Right, if you stand up, you start moving, you need to adjust for the higher activity levels. And again, your autonomic nervous system is going to be really important. That sympathetic fight or flight, or the parasympathetic rest or digest, and then the actions of epinephrine and norepinephrine. Epinephrine and norepinephrine are going to work on beta receptors. You may have heard of beta blockers for the heart. So basically, if someone has too high, they're too high a heart rate, they have hypertension, what they'll do is they'll give them beta blockers, and basically they'll block the effects of epinephrine to bring down their high blood pressure. Okay. Another hormone that will affect heart rate is going to be thyroid hormones. So thyroid hormones will also increase your heart rate as well as contractility. One of the things they look at with people, like if an individual has a really high resting heart rate, sometimes they'll check their thyroid to make sure that they're not overproducing thyroid hormones. Or if their heart rate is too low, they also check their thyroid hormones to make sure they're producing enough. And again, I mentioned this already. Again, epinephrine, norepinephrine both will increase the rate of contractions as well as the strength of contractions. The parasympathetic nervous system, they work by using acetylcholine again, and that's going to decrease heart rate. And then we have some cations that are going to be very important. Again, as we saw, right? We saw potassium, calcium, and sodium in that action potential of the heart. So again, we have to have the right balance. If you have too much sodium that'll block the inflow of calcium in, so that'll interfere with the proper electrical signaling. And then too much potassium in your bloodstream and the interstitial fluid again blocks the actual action potential, so it blocks the signal from occurring in the first place. Okay, so again, we want to make sure we have the right ion concentration. So this is just basically an overview. So things that are controlling your heart rate. So things from higher brain centers, your cerebral cortex, the thinking part of your brain, the limbic system, that's the emotional part of your brain, as well as the hypothalamus that's monitoring chemical levels in your blood, right? So all those things, I mean, think about the things that will regulate your heart rate. So you might, I don't know, just get nervous at a speech. That's kind of your cerebral cortex working. Or you get afraid, something frightens you, your limbic system, right? All those things are going to affect your heart rate. Also, sensory receptors are giving input. So proprioceptors are monitoring movements, chemoreceptors, blood chemistry, baroreceptors, blood pressure. So all of those are giving feedback, basically letting your heart, either increase heart rates or decrease them. And then here you can see the things that are going to accelerate your heart rate, sympathetic nervous system. And then your vagus nerve is that nerve that's part of that parasympathetic nervous system that's going to bring your heart rate back down. Oops. All right, so here is basically a summary image. If you don't like it, you don't have to like it, just ignore it. We've said all of these things, so all the things that are going to affect our cardiac output. Sometimes it's easier almost to work backwards on this image. So okay, so we have our cardiac output, and remember we said it was due to stroke volume and heart rate, where it's going to affect our cardiac output. So if we want to increase this, we need to increase these two, one if not the other. Usually you're doing both. So okay, what are the things that will increase stroke volume? Well, we have to increase the preload, we have to increase the contractility, and we have to decrease the afterload, right? And that basically explains all of those things to you, everything we just went through. If we want to increase our heart rate, we're going to have our nervous system give us our input saying, okay, increase that heart rate. There are certain chemicals that will increase. So you can see this thyroid hormones or catecholamine. So those are things like epinephrine, norepinephrine. And then simply other factors, your physical fitness, body temperature, all those things will lead to an increase in heart rate. Okay. All right. So just a few heart issues. So this kind of last bit here. This is just showing you a kind of a diagram of a heart transplant. So you can see here there's partial left atrium that's been left on the recipient's heart, and then the donor heart gets sutured on to that, mostly because that's where you have the pulmonary arteries coming back. The pulmonary veins coming back in, so that you can kind of see the donor's heart, and then basically they just sew back all the major blood vessels. Really kind of impressive that actually works. There's no leakage and all that kind of stuff. So here you can see normal artery, obstructed artery. That plaque that builds up can be really bad. A lot. They used to think it had to do with a lot of cholesterol in the diet. They're now realizing that it actually has a lot more to do with genetic factors and a predisposition to that. So it's not so much what you eat, but just your genetic factors. So kind of stay tuned for that. We'll talk a little bit more about it when we get to blood vessels. Here you're seeing a grafted blood vessel. So a heart bypass is what this is. So if this is where the blockage was, okay, so you just take another blood vessel from a different body part, so you bypass it, right? So you can still get blood flow going to the parts of the heart that you need. And you can actually watch a surgery. There's a link to it. So here's a balloon that they often do to basically get rid of some of those plaques, and sometimes they can put stents in to keep this passageway open, right? And this is the stent. I have some that I'll bring and show you guys. These are actually blood vessel stents. They're really impressive. So they're kind of they insert them, they're folded down, and they kind of just spring up. right? Keeps that blood vessel open. All right, so this heart, I don't know how obvious this is to you, but one of the things you'll notice is this heart is huge. This is ridiculously big. Normal human heart should be about the size of your fist. I mean, this actually is probably closer to the size of a cow's heart. This is an amazingly enlarged heart. You know, and when the heart gets this big, it doesn't beat as efficiently. The walls are very thick. They have a hard time actually contracting due to their thickness. This is actually this is from a 27-year-old who died from complications of morbid obesity. Yeah, and heart failure. He weighed 423 pounds at the time of his death. Yeah, you know, obviously lots of problems with this heart, right? Here are 4 different images. So let's see if I can remember all these. So this top one I think is pretty obvious. There's a big hole in the heart. That's due to a small caliber gunshot wound. So the person was shot and killed. This one right here, can you see this right here, this kind of spot? That's actually cancer of the heart. The individual passed away. This one, it doesn't look too bad. Maybe it kind of looks a bit reddish, maybe some bruising looking. This is from a teen drug overdose. It's a teen that died of a drug overdose. That's what the heart ended up looking like. And this one, again, maybe not quite so obvious, but can you see like all of this yellow around it? That's a whole lot of fat around the heart. And again, this person died of complications due to obesity. So a few other kind of defects. This top one here, coarctation of the aorta. So basically that means there's this portion of the aorta that's been constricted. It's just, you know, congenitally smaller. Obviously that causes problems as blood's trying to get through there. There's like a pinching point, and you know that causes the aorta to give out, lots of heart problems. Sometimes remember that I talked about that ligamentum arteriosum that helps bypass circulation in the fetus? Well, that should close up upon birth. Sometimes it doesn't. The name of that blood vessel is a ductus arteriosus. It remains open. So you have this combination of oxygenated and deoxygenated blood. Okay. Sometimes there's an interatrial septum, kind of like the interventricular septum. There's a septum between the atria. Again, we saw that the fossa ovalis as sort of the remnant of the foramen ovale. Well, for whatever reason, that foramen ovale fails to close, and again, we still have that mixing of oxygenated and deoxygenated blood. And anytime you have that, again, you don't have as efficient oxygen delivery going to muscles and other body parts. Sometimes there's a problem in the septum of the ventricle. This is obviously a much more serious problem. Again, we have that mixing of blood. And then you have something called the tetralogy of Fallot, and then here's just a series of issues. Pulmonary valve has problems. The flaps are too large. That interventricular septum is defective. The right ventricle is enlarged. The aorta is emerging from both ventricles. So again, massively inefficient heart, not enough oxygen getting to where it needs to be, and lots of overlying health issues. So a couple of EKG kind of things, what they look like. So here's normal, right? So again, we have P, Q, R, S, T wave, right? So here's a first degree atrioventricular block. And one of the things you'll notice is here's that P wave, and then there's this really abnormally long span. So if you look again here, that P wave and then the Q, it's very small. Again, here, there's an AV block. So meaning the electrical signal can't get through as efficiently, so it takes longer. So that's what that looks like. Usually that's due to some scarring of the heart muscle because there's been some death of the muscles. This is what atrial fibrillation looks like. So ventricular, the signal to the ventricles looks good, but then, there's no real P wave. That atria is just kind of fluttering. Okay. And then when you have ventricular tachycardia, the ventricles are just, like your heart is just racing, and not even in a concerted manner, it's just kind of all over the place until finally it's not even these big contractions. They're these tiny, little ventricular, flutters almost. So that's ventricular fibrillation. I mean, If you ever see an EKG like that, that's you do not wait, you run to the hospital. Okay? Well, you wouldn't be able to. Get someone else to do it. Call 911. All right. And that's it for the heart. So, whew, a lot easier than blood, right? So again, if you have any questions, do not hesitate to ask. And then we're moving on to blood vessels. See you next time.